Good morning, everybody. Welcome to the Hicks webinar session. As usual, after every 6 month cycle, we talk about the year that was, look at the salient randomized controlled trials and other publications which have come in the last year, and see how these studies can influence our practice, or how we can change our practice, or how we can get better. So what we try to do is just to select the more relevant randomized controlled trials. Some of them may not be very big studies, but as a concept, they are very, very elegant and practical studies. So such studies is what we normally discuss, and a few meta-analysis. We generally don't talk about guidelines, but we do, if there are any good guidelines that have been published, we do suggest that those guidelines be read. And any of you want to access any of the articles which we are discussing in this journal club, or you can post on the Hicks group, and we will be able to share them with you. This particular session of the year in review, I thought we will do in two parts, because there are too many things to be discussed, and an hour is not probably enough time to discuss everything. So today, and probably the 7th of February, we will discuss about the year in review, and then on the next session of the next cycle of our programs would resume. So let us look at a few important and interesting studies which were published in the field of ARDS. In the last 2 years, previous 2 years during COVID, we knew about biomarkers. We were always testing about serum biomarkers like interleukin-6, D-dimer, and others, and trying to see if these patients are if these patients have a worse form of disease, or they have a more severe form of disease. Similarly, alveolar biomarker profiles have been identified, and the same interleukin-6, interleukin-12, TNF-alpha, and other biomarkers have been studied in bronchoalveolar lavage fluid, and ARDS has been categorized into the hyperinflammatory and hypoinflammatory ARDS. So, if you look at the hyperinflammatory category of ARDS in the bronchoalveolar lavage, you can see that the alveolar biomarker elevation is quite high, above the expected baseline in the hyperinflammatory forms of ARDS, that is IL-6, even von Willebrand factor, IL-1B. All the important biomarkers are elevated in the bronchoalveolar fluid, and their elevation in the bronchoalveolar fluid is totally different from their elevation pattern in the serum. So the blood levels may not actually be the true reflection of what's happening at the alveolar level and at the inflammatory level. So the important aspect to remember is that if we are believers in the biomarker based assays for ARDS, it is better to do the bronchoalveolar lavage based assessment, rather than tailor our treatment looking at the serum or blood levels of the biomarkers. So does it make a difference to the outcomes of these patients is what matters. Definitely what is very obvious here is those patients who have a hyperinflammatory type of ARDS tend to have a higher severe lung injury score, did not tend to have a higher lung injury score, and they did not have worse oxygenation. But what is more important is those patients who had a hyperinflammatory response seem to have a higher disease severity and acute kidney injury, but it did not influence the mortality amongst these patients. In fact, the hypoinflammatory forms of this disease tended to have higher severe lung injury scores when compared to the hyperinflammatory. So we are yet to understand what this inflammatory process is due to, and what is its significance in terms of the overall outcome for patients with ARDS. So trying to modulate the immunity by giving immune modulators like tocilizumab and steroids may not be a justified way of managing these patients may not be a justified way of managing these patients with ARDS, irrespective of what their inflammatory state is telling us. The next important or interesting study which thought we should discuss is the about the titrating your PEEP with either oxygenation or the driving pressure. So after the ARDSNet study was published and we understood the importance of PEEP and the PF ratio, we all followed the PEEP table and were setting the FiO2s and the PEEP according to the PEEP table of the alveoli study. Subsequently, when driving pressure became understood as an important aspect of the pathophysiological management of ARDS, there has been some attempt to manage the PEEP with the use of driving pressure, and the best driving pressure, which can give you the best oxygenation at the acceptable PEEP, was considered to be the most reliable way of managing these patients. So when you compare a PEEP strategy that is based on driving pressure to a PEEP strategy that is based on the PEEP oxygenation table or the oxygenation index, it is very clear that the PEEP levels are a little higher in the driving pressure group. The PEEP level in the oxygenation group, the plateau pressures are also higher in the PEEP based, the oxygenation based group, and the peak pressure, the respiratory system compliance was a little lower in the oxygenation group. And it did not, whether you set the PEEP according to the oxygenation or you set the PEEP according to the driving pressure, you did not seem to have an advantage in terms of your carbon dioxide elimination or pH. But what is important is the oxygenation seemed to be better at a lower plateau pressure, the lower peak pressure, when compared to a PEEP that was set with the oxygenation table. So currently what we can say is that if you are determining your best PEEP with oxygenation and a best PEEP determined by driving pressure, the number of patients who achieve a better oxygenation targets with a driving pressure based strategy seem to be significantly clinically and statistically significant when compared to a strategy where your PEEP is adjusted according to the oxygenation table or the PEEP oxygen table. Therefore, this randomized control trial concluded that depending on the best method, the PEEP level varies, but the PEEP that is set according to driving pressure is lower than the PEEP that is set according to the oxygenation level. And computing the driving pressure now is, everybody knows how to do it. It is a simple, faster and less invasive method than measuring the PaO2 and titrating your PEEP according to the PaO2. But as of now, we cannot say that one method is superior to other in terms of mortality. But if you are basing your decision for extracorporeal therapies based on oxygenation parameters, then I think you should use your driving pressure based strategy to set your PEEP before you say that somebody is not responding to PEEP or we are setting too much of PEEP. That seems to be the message which we get from this study. Now, because of the concerns of what we discussed previously, the hyperinflammatory response related to mechanical ventilation, the adverse effects of PEEP and tidal volume, it is understood or it has been accepted that you can resort to an ultra lung protective ventilation strategy in severe ARDS patients with the help of veno-venous ECMO. So the understanding or the hypothesis or the presumption for that strategy is that if you do a ultra low tidal volume ventilatory strategy with taking the help of ECMO to maintain the oxygenation, you can probably blunt the inflammatory response, you can blunt further damage to the lungs, and you can probably reverse the organ failures that are triggered as a result of hypoxemic respiratory failure and mechanical ventilation. So this is the study design. So at the time of ECMO cannulation, which is less than 24 hours, there was a lung protective ventilation group and an ultra lung protective ventilation group. The lung protective ventilatory group is as per the EOLIA protocol, where you put the patients on APRV with a plateau pressure targeted of less than 25, PEEP of more than 10, and an FiO2 of up to 60%, 30% to 60%. And they monitored the respiratory mechanics, ABG, ECMO settings, blood samples, and the inflammatory markers in the bile sample at recruitment and at 24 hours along with respiratory mechanics. They also looked at the same parameters at the end of 48 hours. This was compared to the ultra low tidal volume ventilatory strategy group, where you use the control as a volume control mode of ventilation at a tidal volume of 1 to 2 mils per kilogram ideal body weight. That is not even 4, not even 4. So you're looking at 1 to 2 mils per kilogram ideal body weight and a PEEP of titrating according to the FiO2 and prone position of at least 16 hours. This was the comparator group for this study. And they found that in the lung protective ventilatory group and the ultra lung protective ventilatory group, the biomarker levels were exactly the same. There was no evidence of hyperinflammation in the conventional strategy compared to the the ultra low protective ventilator strategy. Or conversely, the ultra low tidal volume lung protective ventilatory group did not show a hypoinflammatory response when compared to the normal strategy, which we are already following. And if you look at the interleukin 6 levels, also the levels were exactly the same or reasonably comparable at the end of 48 hours and at the end of at the study. There was no change in the biomarker levels in the ultra low tidal volume level. That means the low tidal volumes did not result in any lesser inflammatory response when compared to the conventional ventilatory strategy. So what was different in the ultra low tidal volume strategy was the mechanical power was less, but that did not translate into a lesser inflammatory response. So this study concluded that despite a significant reduction in the mechanical power, ultra lung protective ventilatory strategy during 48 hours did not reduce the biotrauma in patients with VV ECMO supported ARDS, and the impact of this ventilation strategy on clinical outcomes cannot be taken as granted, and you need to work on it before using the need for an ultra low tidal volume ventilation to put the patients on ECMO with the presumption that it results in lesser inflammation. There may be other advantages of ECMO and lung rest, but inflammation being better is not the answer to why you need to put more patients on ECMO. So after all this, there was a meta-analysis of randomized controlled trials, which in the European Review of Medical and Pharmacological Sciences, which looked at the effect of driving pressure-guided ventilation strategies on patients with mechanical ventilation. And when you look at overall mortality of this group, it favored the driving pressure group. And when you looked at the oxygenation, also the better oxygenation numbers and better oxygenation indices were encountered in the driving pressure driven group. And when it looked at adverse events also like barotrauma and mediastinal emphysema were also less in the group which was managed with in the groups which were managed with driving pressure. So in terms of patient safety, in terms of achieving your oxygenation, and in terms of overall mortality, a driving pressure-based strategy for setting PEEP and achieving oxygenation seems to be better than a PF ratio guided oxygen PEEP table as recommended by the alveoli study. The next aspect of what we reviewed from the literature available last year was fluids, and this was one of the most important study which looked at a lot of issues comparing 20% albumin to plasma-lite in patients with cirrhosis and sepsis induced hypotension called the ALPS study. So this is an important aspect because a lot of patients with liver disease and cirrhosis seem to be the selected cohort of patients in whom we preferentially go with albumin. So is there any advantage is what we looked at. This is the pictorial abstract of this study where they looked at liver cirrhosis patients who are hypovolemic, hypoalbuminemic with vasodilatation and sepsis-induced hypotension, and compared the use of 20% albumin with the preferred balanced crystalloid, that is plasma-lite. And they found that the use of 20% albumin is associated with a faster attainment of the mean arterial pressure target of more than 65 millimeters of mercury. There was a better resolution of hyperlactatemia and a reduced need for dialysis. or those who needed dialysis did so a little later than those who were treated with plasma-lite. But there was no survival advantage with the use of albumin. So morbidity-wise and vasopressor days-wise, probably you have an advantage when you use 20% albumin instead of plasma-lite for cirrhotic patients with sepsis-induced hypotension. But on the other hand, the flip side is albumin was associated with a higher incidence of pulmonary complications. Therefore, 20% albumin is superior to plasma-lite in reversing sepsis-induced hypertension in critically ill patients with cirrhosis, so can be used. 20% albumin, however, does not confer any survival benefit over plasma-lite, and it causes more pulmonary complications than plasma-lite. Patients with pneumonia, higher serum lactate levels and SOFA scores therefore are at a higher risk of pulmonary complications with the use of 20% albumin. So we can say from the ALP study that plasma-lite is a safer fluid for resuscitation of critically ill patients with cirrhosis and pneumonia and lower serum bicarbonate. So there may be some advantages with albumin, but at this point of time, it does not score over plasma-lite as a resuscitation fluid. One of the important aspects when you give fluids is to avoid volume overload, and you also need to understand whether the interventions which you are applying, like a CRRT, to remove fluid is actually effective or not. So we go by very different methods. We go by chart review, we go by weighing the ultrafiltrate, we go by lung ultrasound, we can go by clinical evidence, we can go by echocardiography. An interesting area that has emerged, and we have been discussing this for the last 3-4 years in our journal clubs as well as in our year in review, is the use of bioimpedance vector analysis. Bioimpedance vector analysis looks at where the water distribution is higher, so that whether our ultrafiltration strategies can be improved. So in this, you have a set of patients who had an initial setting of net ultrafiltration rate, and in the control group, you had either pulmonary edema not attributable to other reasons, peripheral edema, or positive cumulative fluid balance. Whereas in the other group, in the intervention group, you had the lean body mass water of content of more than 74.3, and you used the electrical impedance probes to measure the vector location below the major axis. So what it was found, and then they titrated the CRRT settings and the ultrafiltration based on what you found in these patients. So what it found is that the use of electrical impedance tomography based ultrafiltration readjustment was associated with lower water content, a higher ultrafiltration rate, and therefore a quicker renal recovery with urine output, but did not confer any mortality benefit, length of ICU stay, or ventilator days duration. So renal morbidity, renal SOFA scores were probably better with the use of the electrical impedance method, but it did not confer any mortality advantage. So the impedance, the intravascular volume assessment guided ultrafiltration prescription may be associated with a lower rate of fluid overload. And when you understand that fluid overload is an independent determinant of adverse outcomes, maybe you should consider in those patients who have very critical issues with fluid, need for more fluid versus the need for ultrafiltration. We discussed the basics clinical trial in our journal club a few months ago, and we found that there was no advantage with the use of balanced crystalloids in critically ill patients. So subsequently, they went back into the raw data of the basics trial and found out whether the fluid which a patient got prior to being enrolled in the trial had any bearing on the ultimate outcome of the study. That means if my patients were all resuscitated with different fluids in different hospitals and they come to my hospital and I randomize all those patients into the plasma-lite versus the saline group, what the fluid which they received prior to coming to me, did it have a bearing on my outcome, is what this secondary exploratory analysis of the basics clinical trial tried to find out. And not very surprisingly, they found that there is a high probability that balanced salt solution in the ICU reduces a 90-day mortality, among those patients who were exclusively treated with balanced fluids before they were enrolled into this study. So a balanced fluids first and balanced fluids next strategy seem to be associated with a better survival than any fluid of your choice beginning. After the 30 mils per kilogram is over, you put them on to plasmalite. The balanced crystalloid does not seem to be a logical argument anymore in terms of survival. So early treatment, therefore, matters in the critical illness. And there's a very good editorial on this also published in the NEJM, which says that the probable benefit from balanced crystalloids was consistent across planned admissions, unplanned admissions, and unplanned admissions without sepsis and traumatic brain injury. So among the 3,000 plus patients who received only balanced crystalloids before enrollment into the basic study, the outcomes were much better when compared to those who received other crystalloids and albumin prior to being enrolled in the basic study. So we all talk about fluid overload and the detrimental effects of fluid, and we all now have gone back to restrictive fluid strategy. So does it really help? Does restrictive fluid, intravenous fluid in ICU patient with septic shock make a difference for renal outcomes, hemodynamic outcomes, ventilator outcomes, and ultimate survival of these patients? This was an RCT that was published in June in the NEJM, which looked at more than about 1,600 patients and randomized to less than 500 ml for a fluid resuscitation versus the standard 1.5 to 2 liters of resuscitation, and looked at their outcomes at 5 days and 90 days. The patients who are in the restrictive fluid group were, average, they got about 500 ml on the first day, and about a liter and a half after 5 days, and about close to 1.7 to 1.8 liters on day 3 at 90 days, whereas the standard fluid group got close to 1.5 liters, 3 liters, but that seemed to taper off, and they still got 3.5 liters at 90 days. So the cumulative positive balance persisted at 90 days, and the difference was really significant. So in the first day, the difference between the two groups was about 800 ml, 1600 ml after 5 days, and 2 liters after 90 days. You can actually look at the cumulative fluid balance also changing in these patients. And if you look at the ultimate outcome of these patients, there was no difference either in the death at 90 days, adverse incidents like myocardial ischemia, intestinal ischemia, brain injury, or the number of days they spent without life support or outside the hospital. So there are now proponents and opponents of the conclusion. You can say that restrictive fluid strategy does not add to any advantage, it does not give any added advantage, but those who support the restrictive fluid strategy can argue saying that it does not cause too much harm. That means if you restrict fluids, patients don't end up with kidney injury, they don't end up with myocardial ischemia, they don't end up with brain damage. So it is probably not a strategy which will cause organ failure, but it is a strategy which will not improve your outcomes for patients with sepsis and septic shock. The other area where a lot of people believe that you give fluids without bothering about what happens, and we also know it is one of the situations where abdominal compartment syndrome is very common, is acute pancreatitis. And does a moderate fluid resuscitation strategy have a place in the management of patients with severe pancreatitis? So if you call administration of a bolus of 20 mils per kilogram of body weight fluid as an aggressive strategy, followed by 3 ml per kilogram per hour of maintenance fluid, and you have a group where there is a moderate fluid resuscitation which consists of half that amount, that is 10 ml per kilogram of fluid in patients with hypovolemia. And if they're normal volemic, you don't give them a bolus, but give them 1.5 ml per kilogram maintenance per hour maintenance. Does it make any difference? They started off having an initial sample size of 754 patients, but it was stopped after the first interim analysis because of there was safety outcomes without any significant difference in the incidence of moderately severe or severe pancreatitis. Early aggressive fluid resuscitation with 20 mL followed by 3 ml per kilogram resulted in a higher incidence of fluid overload and did not prevent these patients from becoming more severe. So this study actually stopped recruiting patients. So it's an important point for us to know that such aggressive fluid therapy is not really needed in patients with severe pancreatitis. So it is something like some less is more is coming back uh, into fluids, and this is one aspect where we are uh, we go back to conservative fluid strategy. Now, when you talk about fluids and you talk about fluid balance and you talk about keeping the balance even, we talk about loop diuretics, and we tend to give patients a lot of diuretics to keep them dry, or if you're giving them too much fluid, you dry them out with loop diuretics. So does loop diuretic use in adult intensive care with patient fluid overload confer any additional benefit? This was the question which was sought to be answered by this meta-analysis and the trial sequential analysis. So they found that loop diuretics probably will not confer much advantage, but they do achieve the target of a negative overall negative fluid balance among patients in the intensive care unit. Another good meta-analysis which you should all read is about extravascular lung water. Whichever method you measure by lung ultrasound or impedance tomography, extravascular lung water levels are associated with mortality. This is another good meta-analysis which we can all read and understand where we should be targeting our fluid resuscitation strategy. So if you look at the loop diuretics, and you can see that there is some advantage with the use of loop diuretics, and then you can see that there is survival advantage. There is the mortality with extravascular lung water is significant. Now we come to hemodynamics and we look at the capillary refill time measurement. Now, the Andromeda shock trial brought in a very long-standing clinical sign back into practice, made it more fashionable by saying a capillary refill time targeted therapy is superior to a lactate-guided therapy in patients with septic shock. Why septic shock? We were never able to understand. So there people still questioned, is it just that there is a response to shock? So does the performance of early capillary refill time measurement have any bearing on patients with cardiogenic shock? This was the subject of an observational prospective multicentric study in Europe, France, and in Europe and New Zealand, where they tried to assess the correlation of capillary refill time values with 90-day mortality in among cardiogenic shock patients or the need for mechanical support like veno-arterial ECMO. And what is the correlation between the capillary refill time and the hemodynamic parameters? This observational study concluded that in patients with cardiogenic shock admitted to the intensive care unit, a prolonged capillary refill time of more than 3 seconds is associated with an early prediction of mortality or the need for a VA ECMO support. So it can actually buy you time in the sense that you tend to take decisions faster, and you can also prognosticate. So a capillary refill time is not a test which is restricted to the situation or scenario of septic shock, but any patient with shock on whom you're trying to improve the hemodynamics, a measurement of capillary refill time and a failure to improve it are markers of poor outcome, and they predict adverse outcomes in septic shock, but they also will tell you which patient should be fast tracked to a VA ECMO rather than waste time with dobutamine and other mechanical supports. Looking at hemodynamics a little further, critically ill patients are known to have tachycardia for various reasons, whether it is sympathetic stimulation, whether the vasoactive agents which are used, pain, hypoxia, hypovolemia, whatever it is. And this tachycardia traditionally has been considered to be the harbinger of cardiomyopathy among stress cardiomyopathy among patients with trauma, pancreatitis, and pregnant ladies. So, does slowing the heart rate down with a beta blocker have any benefit among critically ill patients? This was a question that was sought to be answered by a meta-analysis, which looked at patients, critically ill patients, way back from 1998 till 2020, and found that if you look at the overall survival of these patients, there is a tendency for favoring beta blockers among critically ill patients whose heart rate is above 120. But when you look at the overall hemodynamic optimization, beta blockers tended to give you a quicker or an earlier hemodynamic optimization, but at the cost of lower systolic blood pressure. But therefore, the systolic blood pressure itself may not be a determinant of poor outcome, but overall, the beta blockers seem to be conferring a survival advantage for patients with persistent tachycardia with a wide variety of critical illnesses. Now, when you look at vasopressors and you look at vasopressor days, you tend to say that patients who require vasopressor for a longer period of time do worse when compared to patients who require vasopressors for a shorter length of time. Is that the only metric? Unfortunately, no. The dose to which you are exposed, what is the highest dose of vasopressor the patient got, what is the mean dose of vasopressor the patient got, will all determine probably the outcome. So balancing the risks of hypotension and vasopressor associated adverse effect is an always a challenge. So you try to improve your map, you step up the norepinephrine, your fingers turn blue or something else happens. So does it really make a difference in trying to give higher and higher doses of vasopressor? So the effect of lower versus higher exposure on mortality needs to be understood. And you look at the patients who are more than 65 and who are less than 65. Those who are more than 65 tend to benefit from a higher exposure, but they tend to have a higher use of vasopressors when compared to those who are less than 65. Similarly, those who are chronic hypertensives tend to have a higher dose, but there is no benefit in giving higher doses of vasopressors to both the groups. Even for patients who are severely ill with a median severity that is very high, the prolonged exposure to vasopressors is an independent determinant of mortality, and it is the incidence of left ventricular failure, and in patients with sepsis, the advantage of a higher mean arterial pressure driven by higher vasopressor exposure is not associated with better survival. Then another interesting study which I thought we should discuss, this is actually one of my students is working on this project right now, is vasopressin versus norepinephrine as a first line vasopressor in septic shock. That means we have used norepinephrine as a first drug of choice for time immemorial. It is still the front runner vasopressor in cardiogenic shock, but is there an alternative to norepinephrine? Is vasopressin an alternative to norepinephrine to start first? This was actually triggered by a shortage of vasopressin in some countries, of norepinephrine in some countries. But does it make any clinical sense? Surprisingly, yes. If you look at studies done before 2004, there seems to be a neutrality. But subsequent trials, once you understood how to give vasopressin and what are the major mechanisms by which it works, the beneficial effect on mortalities in ICU mortality and 28-day hospital ICU mortality seems to be better with vasopressin, especially in those who are oliguric and require renal replacement therapy. But it did not show any advantage in 28-day hospital mortality in patients. So if you look at the patients with the requirement for renal replacement therapy, the patients who are treated with vasopressin first tended to have a lesser requirement for acute kidney injury therapy like renal replacement when compared to those who were treated with norepinephrine first. And contrary to popular belief, it did not add to the severity or the complexity of the adverse effects related to the administration of vasopressin. The last one in this is whether ECMO is something that is more widely available in this country. So we tend to use it more for cardiogenic shock. but does ECMO score over Impella, or does Impella score over ECMO in the management of patients with cardiogenic shock? So in a systematic review and meta-analysis, they used about 10 studies totaling about 1,800 patients with cardiogenic shock treated with mechanical circulatory support, and they looked at the in-hospital mortality, and they found that the risk of in-hospital all-cause mortality was significantly lower with the Impella compared with ECMO, but there was no difference in 12-month mortality. And there was also no significant difference between the two groups in terms of successful weaning and bridging to transplant. But there was less incidence of bleeding and stroke in the Impella group compared to the ECMO group. So over a period of time, as Impella becomes more and more widely available in this country, it may score over veno-arterial ECMO for hemodynamic support among patients with shock. Looking at infections, we always believed that carbapenem resistant organisms should always be treated with a combination therapy. But is it really needed? Is colistin monotherapy enough for patients with carbapenem resistant organisms? So if you look at in this randomized controlled trial, where they compared colistin plus placebo versus colistin plus meropenem, predominantly looking at patients with pneumonia and bloodstream infections, again mostly caused by Pseudomonas and Acinetobacter. What they found is the overall microbiological cure was as good with colistin monotherapy than when compared with meropenem, combination with meropenem. Tendency towards a better resolution of pneumonia with colistin alone, and no difference whether it was Acinetobacter or Pseudomonas based on the organism. Even Pseudomonas, the combination therapy did not do better than colistin monotherapy. So this trial concluded that combination therapy with colistin and meropenem is not superior to colistin monotherapy for the management of pneumonia or a bloodstream infection that is caused by these pathogens. So you don't need to actually jump and write a dual antibiotic if you have a pneumonia or a BSI that is caused by MDR organisms. Now, this is another interesting thing where we now have access to 1,3-beta-D-glucan in quite a few hospitals in the city, and we tend to diagnose fungal infections based on this, and we tend to give antifungal therapy based on positive beta-D-glucan assays in a variety of samples. So the Candicept randomized controlled trial tried to find out if a 1,3-beta-D-glucan guided antifungal therapy is superior than culture-based therapy for patients with sepsis and septic shock. So they looked at the control group, which went by the normal methods of prescribing antifungals, and they did not find that the biomarker-based initiation of antifungal therapy reduced the mortality, neither in-hospital mortality nor 28-day ICU mortality. And more number of patients were alive without antifungals as expected in the control group, and the costs of antifungal therapy were nearly double in the patients who were actually managed with a beta-D-glucan biomarker-based antifungal therapy. And if you look at the Candida colonization index, it also was no different whether you used a biomarker-based approach or you use the clinical, radiological, and conventional microbiological approach. The take-home message of the Candicept trial is that immoderate administration of antifungal therapy happens with the use of a biomarker-based therapy. It is not superior to culture guidance, and it does not affect the mortality. But definite conclusions are not very robust because of the low rate of invasive Candida infections in this study. But the point to be taken is biomarker-based initiation of antifungals is not going to give any advantage to your patients. Now, this is another important, interesting aspect. You'll see this again when you talk about neurocritical care, and that is remote ischemic conditioning in septic shock. That is called as a RICO. Remote ischemic conditioning is something which has been in practice for quite some time, where you apply a cuff you vary the blood pressure at a site that is remote from where the problem is happening, and try to alter the vascular tone and generate the sympathetic stimulus, so that the main system also benefits from the hemodynamic alterations that are happening. It refers to a stimulus that is provided to a distant organ or tissue, like you can be a suprasystolic blood pressure inflation of the arms or legs periodically, which will cover myocardial protection and subsequent myocardial ischemia. This was used among patients with septic shock, and they found that remote ischemic preconditioning did not reduce the severity of organ failure as measured by the daily SOFA scores, but more powered studies are needed, and probably this will be one of the aspects which future students can work on for their project works. Now, corticosteroids have been the bane and the saviors in intensive care in a wide variety of settings. There doesn't seem to be a consensus on when to use them, whether to use them or not use them, and do they actually give benefit, especially in the context of patients with pneumonia. So this systematic review and meta-analysis looked at the association between glucocorticoids and mortality among patients with severe pneumonia. And they found that mortality is higher among patients who are prescribed corticosteroids. So this is an interesting systematic review. Those of you who want this article, I can actually send it to you. Tissue penetration of antimicrobials in the intensive care unit. Every or antibiotic they have categorized about the tissue penetration, what is good for joint, meninges, kidney, liver. Everything is very nicely written. I can send it to you for those. Please do drop in a message with your email IDs on the Higgs group, and I'll be able to send it to you. Liver and liver related intensive care is something that is catching up, and more liver care units are coming up. So hepatology also became an important. So different vasoactive treatments like midodrine, like terlipressin, like vasopressin, norepinephrine are applied to patients with hepatorenal syndrome. Is there a method? Is there a method or is there a scientific rationale for the use of these vasoactive treatments is something that needs to be looked at. So if you look at the reversal of shock, terlipressin seems to be the best performer. Octreotide, not very good. In terms of mortality, the best results seem to be with terlipressin, but also the more serious side effects are also to be attributed to terlipressin. At this point of time, an equivalent benefit with lesser side effects seem to be happening with norepinephrine, and definitely not with dopamine. And midodrine does not confer as much reversal of shock as either terlipressin or norepinephrine. So if you are looking at a younger patient who is not at a very high risk of myocardial ischemia, maybe terlipressin should be a drug of choice. But if you have any of the caveats for the use of terlipressin, norepinephrine is probably the second best vasoactive treatment for patients with hepatorenal syndrome. So the conclusion of this meta-analysis is that terlipressin increases the hepatorenal syndrome reversal compared with placebo, and it may reduce mortality. And unless access to terlipressin improves, initial norepinephrine administration may be more appropriate than the trial with midodrine and octreotide. So this is the conclusion of this particular meta-analysis. Now, thromboelastography has become an integral part, like an ABG and ECG. It has become an integral part of ICU monitoring and interpretation among patients with ECMO liver failure. So, does it actually, make your blood management any more scientific, especially in cirrhotic patients? Multiple studies have compared a TEC-based versus just a PT-INR-based transfusion strategy for patients with cirrhosis. What we can find is that if you look at the overall transfusion rates, it favors thromboelastography. If you look at the number of products transfused, it favors elastography. And if you look at the platelets transfused and FFPs transfused, it favors thromboelastography. And when you look at the primary outcomes like FFP units, it definitely favors thromboelastography, and safety wise, it also favors thromboelastography. So TEG probably is an integral part now of deciding the transfusions among patients with cirrhosis. A few studies on the metabolic resuscitation, predominantly vitamin C. The vitamin C, as part of the HAT protocol, was studied, and the hydrocortisone ascorbic acid thiamine combination has been frowned upon. So the Lovett study looked at whether intravenous vitamin C in patients who are given a very high dose of vitamin C makes any difference. Unfortunately, it did not. In fact, the vitamin C group tended to show a higher mortality and possibly higher vasopressor use and a higher use of mechanical ventilation. Even the secondary outcomes like quality of life and pain or discomfort were no different in the vitamin C group when compared to no vitamin C. So in a meta-analysis, they did not find any benefit, or no vitamin C was probably a little superior to vitamin C for patients with septic shock. Neurocritical care, not too many, but some important. Again, they spoke about remote ischemic preconditioning in ischemic stroke, and this is one area where they tried to randomize about 1,800 patients with remote ischemic preconditioning in a Chinese study, and they tried to do the same ischemic preconditioning as we discussed before, and they found excellent functional outcome at 90 days. That means a modified Rankin score of about 0 to 1. So this has to be replicated in a second study, which is appropriately powered and so. Over the years, we have tried to manage traumatic brain injury with the use of ICP. Then the invasive ICP monitoring fell out of fashion after the publication of the Bogota study. And then we all are trying to manage it with CTs and optic nerve diameter and transcranial Doppler. But one aspect of all this is preserving the brain oxygenation. So does the monitoring of invasive brain oxygen pressure alter the outcome of patients who are managed with the PbTO2? So this systematic review compared only studies comparing the brain tissue partial pressure of oxygen with ICP guided therapy, and they studied the primary outcomes as 3 and 6 months Glasgow outcome scales, secondary outcomes like hospital and long-term mortality, and brain tissue hypoxia. And when compared with ICP guided therapy, the use of combined PbO2 ICP guided therapy was associated with a higher probability of favorable neurological outcome and of hospital survival. So those centers which have the ability to put a microdialysis probe and measure the brain tissue oxygen function should probably include it in their management strategy for patients with traumatic brain injury. Clinically, sedation scores, we have a lot of sedation scores, and there is a lot of subjective variation in the sedation scores which we use. So does BIS, the bispectral index, does it correlate with the clinical sedation score? The BIS index is a numerical score which can be replicated and which can be reproduced. So does BIS have a role in adjusting the sedation of these patients in comparison to the conventionally accepted sedation and delirium assessment tools? So in this study, in a systematic review, it was found that the bispectral index demonstrated moderate to strong correlation with the clinical sedation scales in the ICU, providing preliminary evidence of the validity for BIS as a measure of sedation. Sometimes you cannot lighten the sedation among critically ill patients for various reasons, and that becomes an excuse for not monitoring the sedation. In such patients, BIS may be a good enough alternative to assess the neurological status of somebody who is deeply sedated. That brings us to the point of sedation. What is the role of dexmedetomidine in patients with sepsis? There is a lot of concern that dexmedetomidine causes bradycardia, hypotension, and it may be a little detrimental. So this meta-analysis of randomized controlled trial concluded that dexmedetomidine could significantly reduce mortality in patients in whom benzodiazepines were used before. But if propofol is your default sedative, then dexmedetomidine does not confer any advantage. But what dexmedetomidine can do is significantly decrease the inflammatory response in patients with sepsis as compared to other sedatives. And dexmedetomidine theoretically and practically may lead to an increased incidence of arrhythmias, but its safety profile did not show any increase in the side effects, although the manufacturer claims that there could be a higher incidence of arrhythmias. So dexmedetomidine and propofol were compared head-to-head in a systematic review and found that dexmedetomidine did not significantly increase the length of hospital stay compared with propofol, but it did have a better effect on reducing the duration of mechanical ventilation and the risk of delirium among cardiac surgical patients at the risk of producing bradycardia across ICU patients. But these bradycardia were not hemodynamically significant in a majority of these patients. So we will stop here and we'll take comments from Ghanshyam, and we will resume the second half next week.
Thank you, Srinivas, for covering various aspects of intensive care with the latest year in review. I mean, we all look forward to this session because it kind of summarizes what we have not studied in the last 1 year. Just want to ask you one question. Any of the studies that you have mentioned, you are looking at getting into a practice or something that you have already done?
Sorry, I didn't get the question, Sham.
Any of the studies, right, where you think that you have, you should get back into our, kind of incorporate those things into our practice, making some difference outcomes?
Yeah, I think the first study I discussed about driving pressure. We should now get out of the focus on PF ratios and oxygenation and use driving pressure to set PEEP. Moderate your PEEP levels more with the use of driving pressure, I think, is something we should do more. And maybe look at Vasopressin with a little more lenient viewpoint. I think these two practices, I think we can straight away bring it into our practice. Interestingly, we should also look at electrical impedance tomography for our patients who are on CRRT to see whether we are actually achieving the targeted ultrafiltration or not.
With respect to Vasopressin, you would agree that we were one of the first teams to start Vasopressin very, very early.
Yeah.
I mean, our second line as Vasopressin, we would start it at a very early time, the moment NORAD goes up a little bit.
Yeah.
Okay.
Yeah. So that's it. If there are any requests for the articles which we have discussed in this, please do drop a message on the Higgs group, and me and Sham will try to provide those articles to you. Thank you very much. Have a good day, and we'll meet you again.